This presentation discusses selection of a spinal instability criteria as an indication for spinal fusion. The International Society for the Advancement of Spine Surgery published the following guidance that is in agreement with many other textbooks, literature reviews, and reimbursement guidance documents. It states that in those patients that cannot be treated non-operatively, lumbar spinal fusion is used to restore local stability, but proper patient selection is essential. An objective diagnostic test for spinal stability is clearly required to implement this guideline. There are several important facts to consider. First, in almost all published lumbar fusion studies, the data document a subpopulation of patients that had much better than average outcomes. It is important to understand why some patients got a much better outcome than did others. Spinal instability is a very well accepted indication for spinal fusion. A reliable, pre-treatment diagnostic test for instability may help identify optimal candidates for fusion. For at least 7 decades, researchers have searched for a reliable test for spinal instability. In 1944, Knudsen published a paper focused on the importance of a test that can provoke instability if it exists, and that patients can experience symptoms due to instability. In 1985, Kirkcaldy-Willis, who was then president of a spine society, described in a lecture 3 questions that needed to be answered. First, he recognized a need for a clear definition of instability. Second, he noted the need for an instability test. And third, he recognized that there would likely be optimal treatments that are dependent on the degree of instability. In a 2001 publication, Nizzard recalled the 1985 lecture of Kirkcaldy-Willis and lamented that 14 years later, despite many research efforts, including investigations of new imaging modalities, the 3 questions asked by Kirkcaldy-Willis remained unanswered. A recent Google Scholar search, for exact phrases that would be expected in relevant spinal instability research studies, reveals thousands of research studies that addressed instability in the lumbar spine since Nizzard's 2001 paper. Despite these hundreds of thousands of man-hours and associated resources spent on all of this spinal instability research, there is still no validated, standardized test for spinal instability in routine clinical use. One of the most common approaches to detecting instability is to measure intervertebral rotation or translation from flexion-extension radiographs, and then apply thresholds to classify motion as normal or abnormal. This approach was used in the American Medical Association's Guide to Rating the Severity of Impairment. Specific measurement methodology was described. Countless people received a disability rating based in part on these assessments. These guidelines have also been used in many research studies, including FDA-regulated studies. Given the impact on patient lives, a robust justification for the AMA guidelines would be expected. The basis for these guidelines can be found in a book by Punjabi and White that is considered an important go-to reference for spinal biomechanics. In fact, the guidelines used by the AMA are based on results from one small 1982 laboratory study of 7 cadaver spines using what would today be considered very crude methods. Importantly, these guidelines have never been clinically validated for standard diagnostic metrics such as sensitivity and specificity. It is also important to realize that a symptomatic patient may resist moving into a flexed or extended position, and the test may document little motion even in cases where there would be abnormal motion if the patient had a need for greater flexion or extension motion. In other words, false negatives would be expected. In addition, many asymptomatic people with healthy spines will exceed the motion thresholds obtained from the small cadaver spine study. A wide range of other intervertebral motion thresholds have been used, including criteria and payer reimbursement guidelines. These guidelines also have very limited scientific support. One criteria that has been used in many research studies is to classify a level as unstable if there is greater than 10 degrees of intervertebral rotation. This criteria can be traced back to a 1995 paper where the author stated that most surgeons define segmental instability as either 10 degrees of angular motion or 4 millimeters of translation. There was no references provided to support where those data came from. Nevertheless, based on this one sentence in one paper, the 10 degrees threshold propagated through research and clinical practice. Most asymptomatic people will exceed 10 degrees of rotation. The FDA has allowed a variety of spinal instability criteria into regulated trials. For example, in the PRODISC-L study, the criteria were greater than or equal to 3 mm or greater than or equal to 5 degrees of angulation. These criteria do not make sense based on available knowledge. Interestingly, although the summary of safety and effectiveness states that this instability criteria was required for inclusion, subsequent publications on the study state that inclusion was based on a lack of instability per these criteria. These same criteria were also used in the FDA-regulated ActiveL study. The Coflex IDE used the criteria from the White and Punjabi textbook that were previously discussed. The Infuse study used criteria similar to the PRODISC study, except with a slightly larger translation criteria. This variability is evidence that the FDA does not have strict guidelines about spinal instability criteria. The FDA will generally accept criteria if they can be scientifically justified. There have been multiple review papers published addressing the challenge of diagnosing spinal instability. The review by Nazard et al. Concluded that, despite many efforts, there is no clear and widely accepted definition of lumbar instability for lack of radiologic criteria. The review by Leone et al. Concluded that the concept of instability is subject to considerable debate, that there is no accepted definition, and the diagnostic approaches are controversial. The review by Simmons et al. Concluded that the clinical importance of spinal instability is recognized, but there is a lack of agreement on how to diagnose instability. One of the most promising solutions to this challenge of diagnosing spinal instability was first reported by Weiler et al. They measured, from flexion and extension radiographs, the magnitude of intervertebral translation divided by the intervertebral rotation. Dividing by rotation minimizes the influence of variability in how much effort each patient exerts when asked to flex and extend. Weiler et al. Found that the translation divided by rotation was significantly greater in symptomatic patients. This slide helps to illustrate the concept of measuring the translation of a specific anatomic landmark on one vertebra, and then dividing that translation by the magnitude of intervertebral rotation. However, this ratio is not of value without robust data defining normal intervertebral motion. In order to know what is abnormal motion, we must first carefully document normal intervertebral motion. This was done by collecting flexion and extension radiographs for several hundred asymptomatic volunteers who had never had any lasting back pain. These are data from one of the studies. Very importantly, QMA was used to obtain these measurements. It is critical to use the same measurement technology for both patients and the control population. There are significant differences in motion between levels, so it is necessary to define normal in a level-specific manner. For example, data for L2, L3 should not be used to define normal for L4, L5. Note that the translation measurements are expressed as a % of end plate width. That accounts for the variability in vertebral size between individuals. This graphic shows three-dimensional reconstructions from high-resolution CT exams of the 4th and 5th lumbar vertebrae. The right half of the spine has been removed to show the mid-sagittal plane of each vertebra. The flexed and extended positions of the spine are shown superimposed to illustrate the motion of L4 relative to L5. The L5 vertebra is stabilized so it remains in a constant position on the display between flexion and extension. On both the left and right sides, there is 13 degrees of rotation of L4 relative to L5, between flexion and extension. On the left side, the small magenta arrow shows the small amount of translation that occurs in a healthy spine. The right side shows an abnormal amount of translation. The translation per degree of rotation can be calculated from raw measurements of intervertebral translation and rotation. The calculated ratio could then be compared to a table of data for asymptomatic, healthy spines. That would allow classifying a level as normal or abnormal, but it is also valuable to know how unstable and to be able to calculate changes over time. We take advantage of knowing the mean and standard deviations for the healthy spines, and that the data are normally distributed. Medical Metrics calculates the translation per degree of rotation and provides the results as a z-score called the Sagittal Plane Shear Index, with the acronym SPSI. SPSI documents how many standard deviations away from normal are the measurements for a specific patient. A z-score is a very well-established way to present medical data that is familiar to clinicians. If the translation per degree of rotation is exactly average for the healthy spines, then SPSI is 0. If SPSI is greater than -2 and less than +2, then the translation per degree of rotation is within the 95% confidence interval for the asymptomatic volunteers. If SPSI is greater than 2, we know that it would be rare to find this in an asymptomatic person with a healthy spine. In fact, it would occur in less than 2.3% of healthy spines. If SPSI is much greater than 2, this is very abnormal. Within a healthy spine of a single individual, SPSI is fairly consistent across levels. So, if most levels have SPSI that is approximately -1, indicating that the person's spine is generally on the stiffer side of normal, but one level has a SPSI that is +1.5, then it is reasonable to suspect that the high SPSI level is abnormal for that patient. SPSI is calculated from flexion-extension radiographs. This is one example. Here, you can see flexion and extension radiographs being alternately displayed. We are flipping back and forth between the flexion and extension X-rays. The first sacral vertebra is stabilized, meaning that it remains in a constant position on the display while the images flip back and forth. At the L5S1 level, the translation per degree of rotation is 3.3 standard deviations greater than the average found in asymptomatic controls. This is abnormal motion. At L4-L5, SPSI is almost exactly the average found in healthy spines, whereas SPSI is 6.5 standard deviations greater than normal at L3-L4. At L3-L4, most clinicians would likely not need SPSI metrics to appreciate instability, but at the other levels it may not be so obvious without SPSI. As previously mentioned, the translation that occurs in a healthy spine is small. SPSI requires accurate and reproducible measurement methods. SPSI is calculated using intervertebral translation and rotation measurements that were obtained using quantitative motion analysis technology. QMA is the acronym. Independent research laboratories have validated QMA as described in multiple, published studies. The QMA method has been used to generate intervertebral motion data for many spine studies. So far, QMA data have appeared in over 120 peer-reviewed publications and hundreds of abstracts. These are a few of the QMA validation studies. Please note that these studies are from some of the most prominent of biomechanical research laboratories. An important quality of a diagnostic test is that it can detect abnormalities in a patient population where abnormalities would be expected. Instability is expected in some lumbar spinal stenosis patients. SPSI has been measured at the treated and adjacent levels in multiple large spinal stenosis trials. All clinical trials were studies of surgical treatments for spinal stenosis. It is remarkable how consistent are the preoperative rates of abnormal SPSI in these studies. At the level identified by clinicians as in need of treatment, 25 to 30% of levels were found to have abnormal SPSI. Interestingly, approximately 40% of all patients had abnormal SPSI at some level in the spine. But the abnormality was at a level adjacent to the level identified for treatment by the clinician. Data for 2 lumbar disc arthroplasty IDE trials are also shown for reference. Spinal instability is generally considered to be an exclusion criteria in disc arthroplasty IDE studies. Abnormal SPSI is in fact far less common in the disc arthroplasty study patients compared to spinal stenosis patients. The facet joints provide substantial stability to a healthy spine, and there is normally no more than a thin gap between the articular processes that form the facet joints. As shown by the yellow arrows in this figure that shows a three-dimensional reconstruction created from a CT exam of a healthy spine. In some patients, an abnormally thick gap can be found between facet joints, and the gap can fill with fluid and be seen on an MRI exam, and this is known as the facet fluid sign. An example is shown here. The green arrows point to the thick fluid-filled gap at the right and left facet joints. The facet fluid sign is currently considered to be one of the best available diagnostic indicators of instability in the lumbar spine. This is an example of one paper validating this conclusion. There are many peer-reviewed publications on the facet sign. SPSI has been shown to be significantly elevated in the presence of the facet fluid sign. This finding has been published in the peer-reviewed literature. This provides evidence that abnormally high SPSI is associated with instability. The possibility exists that SPISI could potentially replace an MRI exam that is ordered with the goal of detecting the fluid sign. In summary, SPSI provides a solution to a 7+ decade search for a spinal stability diagnostic. The justification for use of SPSI in a clinical trial includes: it is calculated using well-validated measurement technology. It uses a large sample of asymptomatic volunteers to define normal motion. It controls for variability in patient size by using translation measured as a % of end plate width. It controls for variability in patient effort by using the ratio of translation divided by rotation. It reports motion in an easily understood z-score. Changes over time can be objectively and reliably calculated. It is validated in reference to what is currently the best available indicator of spinal instability. It reproducibly documents instability in populations where instability would be expected. It does not find instability where it would not be expected. It requires only easily obtainable flexion-extension radiographs. Thank you for your attention, and we hope that you found this presentation on the challenges of documenting spinal instability to be valuable.